Hello, as you may or may not be aware, my name is Ashley. I'm wanting to take this time today to talk to everyone as a recap into the management of seizures, in particular tonic-clonic seizures. The topics I'll be covering today include introduction into seizures, pathophysiology, clinical features, physical examination, pharmacology, relevant investigations, transport decision making, leadership role, and lastly a summary. Introduction into seizures. A seizure is an episode of abnormal neurological function caused by inappropriate electrical discharge of brain neurons. Seizures can be classified into two main groups, either generalized or partial. Generalized seizures are caused due to simultaneous electrical firing of the entire cerebral cortex, typically beginning deep within the brain and spreading outwards. Tonic-clonic and absent seizures are the most common type of generalized seizures. However, myoclonic, tonic, clonic, or atonic seizures are also all different types of generalized seizures, while partial seizures are localized to a specific region of the cerebral cortex. Partial seizures can be then categorized into simple or complex. In simple partial seizures, the electrical firing remains localized and the person's conscious level isn't affected, whereas complex seizures, the conscious level is affected. Now moving on to pathophysiology. Epilepsy refers to recurrent abnormality in motor, sensory, or physiological function and occurs due to unregulated firing within the cerebral cortex. Seizures occur to these susceptible people due to a group of dysfunctional neurons in which they begin releasing excessive amounts of excitatory signals. This occurs due to either a reduction in the inhibitory neurotransmitter GABA or an increase of the excitatory neurotransmitter glutamate. GABA is the most prominent postsynaptic inhibitor within the cerebral cortex and also been found to be an effective presynaptic inhibitor within the spinal cord. Within the brain and the nervous system, GABA binds to the GABA receptors, which controls the opening and closing of the negative chloride channels, where glutamate binds to the NMDA receptor and allows for positive calcium ions to enter the cell. The opening and closing of the channels controls the polarization and depolarization of the cell membrane. However, people with epilepsy often have dysfunctional GABA receptors and as a result are unable to inhibit the signals. Due to this, there is a rise in the cell membrane's polarization above the normal resting membrane potential, which brings it closer to the point where an action potential is formed. The increase in resting potential generates a greater potential, which allows for stimulus to trigger an action potential. Subsequently, there will be larger amounts of and repetitive action potential along with synchronized firing of neurons, which creates the abnormal cognitive and motor function seen during a seizure. And moving on to clinical features. The clinical features present in a tonic-clonic seizure begin with a sudden decrease of conscious level with associated motor movements. This involves a rapid increase of muscle tone and muscle contractions to produce a stiffening of the body, which is known as the tonic phase. This occurs as the action potential is being transmitted through the brainstem from the cerebral cortex. Often at this point, the patient may become apneic. This is due to a formation of atypical neuronal signals in the spinal cord. The body will attempt to compensate for abnormal signals by using the inhibitory pathway within the brain to stop further spread. However, this doesn't take an immediate effect and the patient enters the clonic phase, which is associated with rhythmic motor movements. The seizure will continue until there is a complete stop of the abnormal electrical firing within the brain. However, if the inhibitory pathway becomes overwhelmed, the seizure may become prolonged and develop into status epilepticus. Further to this, the patient may also become incontinent during the seizure and mouth trauma may occur, typically to the lateral aspect of the tongue. During a seizure, there is a 60% increase in oxygen consumption, therefore oxygen supplies are readily used. This, in combination with a potential apneic period, can result in an increase in lactic acid and cell ischemia within the brain. Once the seizure has ceased, the patient will often experience a postictal state. This is a transient state, while the brain returns to normal baseline and is associated with lethargy, confusion, and amnesia. Right, now physical examination. The physical examination should begin with assessment of the airway breathing, and circulation. If during the primary survey any potential problems are identified, they should be addressed and basic life support should commence. The airway should be inspected and any obstructions to be cleared, preferably using the suction. If required, an oropharyngeal or nasopharyngeal airway should be inserted. The assessment of breathing is important. As stated above, often patients can be apneic during a seizure. If respiratory rate is inadequate, then high flow oxygen should be provided to help reverse the hypoxia. Finally, circulation. Often patients will be tachycardic along with diaphoretic and pale. Additionally, a full set of vital signs should be completed, in particular blood sugar levels, as blood sugar can become depleted from the seizure. Furthermore, completing a 12-lead ECG can assist in identifying the underlying cause. A secondary survey is also an important part of the assessment, as patients are prone to traumatic injuries from the clonic phase of the seizure. Obtaining key history with attention to history of seizures, severity and frequency, along with medications and compliance, past medical history and social history. Finally, a neurological assessment is also an important part of the examination, which can assist in identifying a potential cause of the seizure. Overall, there are a multitude of aspects which encompass a physical examination. However, it is important that all are completed so a complete clinical picture is formed. Alright, now moving on to pharmacology and management. Management for a seizing patient is often supportive care. This is because in a large amount of cases, the seizure terminates spontaneously prior to paramedics' arrival. Nonetheless, a seizing patient has the potential to become a medical emergency. A seizure which lasts longer than 5 minutes or multiple seizures without full recovery is classified as status epilepticus and is considered a medical emergency. Treatment for a patient actively seizing involves airway support, oxygenation, protecting the patient from danger, and benzodiazepine administration. Airway management involves placing the patient in a lateral position to assist in reducing the risk of aspiration, along with suctioning to remove secretions, and finally basic airway adjuncts like oropharyngeal and nasopharyngeal airway if the patient is unable to maintain their own airway. Oxygenation is also an important aspect of seizure management, as patients can become hypoxic during seizure activity. Oxygen should be delivered at 15 litres per minute through a non-rebreather mask. Placing a pillow under the patient's head and removing any nearby objects away from the patient can assist in reducing the potential for further injuries. If the seizure has not self-terminated, benzodiazepine administration may be required. Midazolam is a type of benzodiazepine and works as an anticonvulsant with amnesic and sedative effects. Midazolam binds to the benzodiazepine site within the gamma A receptor in the nervous system, central nervous system. This causes an increase in the efficacy of GABA, which allows for greater inhibitory effects and reduces the amount of action potentials forming and being transmitted, thus causing better regulation of the neuronal activities. The increase in GABA also causes chloride channels to open, allowing for an influx of negative chloride ions into the cell and resulting in a subsequent reduction in the resting cell membrane potential. The decrease in resting membrane potential reduces excitability of the neurons, which in turn reduces any seizure activity. Midazolam is a water-soluble solution. As a result, can be absorbed via mucous membranes, thus making it a great option for intranasal administration compared to other benzodiazepine medications. Administration of benzodiazepines during a seizure is a controversial topic. Per Queensland Ambulance Service Clinical Practice Guidelines, midazolam should be administered to a seizing patient with a GCS below 12, irrespective of the length of time a patient has been seizing. However, most literature advises benzodiazepine administration for seizures last longer than 5 minutes in length. A study completed by Silverman and co-authors in 2017 recommended benzodiazepine only to be administered to status epilepticus patients. This was further emphasized in an article by Cashmore in 2010, which outlined that benzodiazepine should be administered if the seizure lasts longer than 5 minutes, due to most epileptic seizures being self-limiting, thus requiring no treatment. Nonetheless, Queensland Ambulance Service guidelines recommend 5 mg of midazolam, either intranasal or intramuscular, as a frontline treatment for generalized or focal seizures with a GCS below 12, which can be repeated every 10 minutes with a total max dose of 20 mg. Intravascular midazolam is only to be administered if IV access is already in situ, which coincides with the literature who outline that IV access in an emergency situation carries significant infection risk and also delays midazolam administration compared to intranasal or intramuscular. Interestingly, New South Wales ambulance service is similar to QAS in that midazolam can be administered to a seizing patient regardless of time. Diazepam is also another benzodiazepine commonly used in the treatment of seizure. A retrospective analysis was completed comparing both midazolam and diazepam. 98% of the adult participants who had their seizure terminated with a single IV dose of diazepam, while 57% for a single dose of IV midazolam and 64% for intranasal midazolam. Although diazepam appears to be superior in terminating a seizure, it is relatively insoluble in water, as a result cannot be administered intranasal, compared to midazolam, which can be administered intranasal, thus reducing the inherent risk of infection and decreasing the time to midazolam administration due to intranasal being significantly quicker to prepare, all while still having a relatively high efficacy rate. Postictal state is a transient brain condition where a patient can experience sensory, cognitive, and motor deficits and occurs after a seizure. Symptoms can vary in severity and may last for a few minutes to hours or even days. Clinical manifestations include unresponsiveness, confusion, declined memory, fatigue, headache, paresis, delirium, and psychosis. The exact pathophysiology of why postictal states occurs is not completely understood. However, there are varying hypotheses, ranging from neurotransmitter depletion, changes to extracellular potassium and calcium levels, and neurovascular decoupling. However, the most likely hypothesis is due to hypoperfusion and hypoxia. Blood flow and cerebral oxygenation concentrations have been shown to be dramatically decreased for more than 1 hour post-seizure due to local vasoconstriction. This was further identified under MRI, showing decreased blood flow to the affected region of the brain in postictal patients. Oxygen administration should routinely be given to postictal patients to assist in counteracting the hypoxia until patient returns to normal baseline. Alrighty, now relevant investigations. In-depth history taking is an important relevant investigation in regards to seizure management. Gaining a detailed history of the episode from the patient and any bystanders, along with questioning about the description of the episode to determine if it is true seizure activity. Key avenues of questioning include presence of an aura, abrupt or gradual onset, presence of uncontrolled motor activity, incontinence of urine or feces, and mouth injury, along with determining the length of the seizure and the presence of postictal state or confusion. Additionally, identifying the clinical context of the seizure is important. If the patient is a known epileptic, confirm if the seizure is consistent with previous seizures and if there have been any recent changes of anti-epileptic medications. Another important investigation is to complete a neurological examination, which forms part of the overall patient evaluation. A neurological examination should be performed for any patient with an altered level of consciousness or neurological abnormalities. There are 5 important areas that form a neurological assessment. First is assessing the level of consciousness through APS. Second is assessing pupils to ensure they are equal in size and reactive. Third is motor function, which involves assessing muscle coordination, strength, and tone. Fourth is evaluating sensory function by assessing a patient's ability to hear and understand verbal communication. And finally, completing a full set of observations. Completing both in-depth history and neurological assessment allows for a full clinical picture to be formed. Now moving on to transport decision making. Transport is essential for a patient who has received midazolam to terminate the seizure, and early pre-notification to this accepting hospital as appropriate. However, if the seizure has self-terminated and no midazolam was required, then transport is not always necessary. However, it is important that the patient is a known epileptic, the seizure was of normal baseline seizure, the patient has made a full recovery, and the patient has obtained no injuries. Furthermore, for a patient to be able to refuse transport, they must be able to demonstrate competency and capacity, be alert and orientated, be able to understand the risks of refusing transport and showing no signs of intoxication. Recommendations should be made for the patient to book an appointment with their GP or specialist if appropriate, and all findings should be thoroughly documented. Leadership role. Leadership is an essential part of paramedic practice, and all paramedics are expected to be able to demonstrate strong leadership skills regardless of clinical level. The important skills that can be attributed to quality leadership include situational awareness, decision-making skills, teamwork, ability to communicate, ability to manage stress, and cope with fatigue. Being able to demonstrate those skills aforementioned when managing a seizing patient who has the potential to become critically unwell is vital for optimal patient care. A leader needs to be able to oversee patient care and gain a bird's eye view of the scene to minimize the potential for mistakes. Often the scene leader is not necessarily the highest clinical level, as often senior clinicians are required for patient management, thus highlighting the importance of all paramedics to be strong leaders. Alright, and just a summary. A seizure is an episode of abnormal neurological function caused by inappropriate electrical discharge of brain neurons. Seizures can be classified into two main groups, generalized or partial. Generalized seizures are caused due to simultaneous electrical firing of the entire cerebral cortex, while partial seizures are localized to the specific region of the cerebral cortex. Tonic-clonic and absent seizures are the most common type of generalized seizure, where simple and complex are the most common partial seizure. Treatment primarily involves supportive care of the airway, oxygenation, and midazolam administration. History taking is an important aspect of patient care, determining if the patient is a known epileptic and if the seizure is of normal baseline for the patient. That concludes my presentation. I hope you enjoyed it and have learnt something in which you can apply to your next seizing patient or postictal patient. I'll finish off the presentation by flicking through my references. Thank you.